Hello, everyone, and welcome to another episode of Fertility Docs Uncensored. I am one of your hosts, Dr. Carrie Bedient from the Fertility Center of Las Vegas, and I am joined by my two vivacious, vibrant, I was trying to think, not
Voracious.
voracious, no, vivacious. That's what I meant. I'm like,
Vivacious.
no, I
I
mean, we do
was
have a good
voracious
time
a
when we
minute
go out
ago,
to
but I ate
dinner, but
lunch.
that's not really the set of adjectives I was planning on. Vivacious and vibrant. That's what I was looking for. Anyway, Dr. Abby Eblen from Nashville Fertility Center
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center. How are you guys doing?
We are
Doing
good. We
great.
are good.
How's your weekend been?
It's been fun. You got to go do something fun this weekend, didn't you?
Uh-huh. We went to a concert with some friends on Friday night, and we went to go see Adele.
Did you go to the big dome? Oh, that's you too, right?
It's U2 is the Sphere, and
The
so that's
sphere.
that's different. And that show just ended, and I think they're trying to get Beyonce to come to that one next. I don't think that
Ah,
they haven't released anything just yet, so we don't totally know what's coming to the Sphere next. Although I've heard amazing things about the people who've gone to see that it's super cool.
okay. So Adele, I thought she was done there because I was in Las Vegas last summer and it was on a weekend. They're like, oh no, she didn't perform on the weekend. It's just during the week. And so I thought her run was over like in the fall or something. I didn't know she was still performing in Vegas.
No, she extended out. She's doing, I think it's about
Ah,
100 shows total, and she's like on
really?
number 771, I think is what she said
Oh,
when we were there.
really? Oh
Yeah.
man, I love Adele. I want to go see Adele. So tell me
It
about
was
it. What was it like? I'm so jealous.
freaking amazing.
Was it?
She's like, I now understand when she canceled her initial start, whenever that was. I
Right.
totally get why she did it because this was just on point. And
Uh-huh.
it was absolutely incredible. Like all of the songs, all of the background musicians, all of the stagecraft, all of it. I mean, so one of my friends is a musician and she's a cellist. And so she's in the background, like the backup
Oh,
Oh,
orchestra
that's
for them.
cool.
And so like getting a little bit of the details from her, and it's just oh, such a good show. She's very personable and she's lovely on all the chit chat between songs and that kind of thing. Like she's funny.
Oh,
It was well worth it.
oh
Aw, that's
man. I want to
fantastic.
fly to
I'd love to
Vegas
see
and
that.
come see Adele.
You
That would be
totally
so
should.
much.
You can stay with me.
Okay, there you go. I wonder if there's any tickets left though. She's probably sold out till the end.
Yeah, that's one of those things where at this point you have to just call the day of because they don't want any empty seats. So when
Yeah,
people turn around and give up tickets, they turn around and sell them.
yeah.
And it's usually not for a huge markup, but they're, all the concerts in Vegas are expensive.
Yeah.
That's
Oh
cool.
wow. That is
Yeah.
really cool. I
All
love
right. What
Adele.
questions do we have today?
Okay, we have a question from someone who has taken off with our wonderful alliteration. Great, fabulous, fascinating, and fierce fertility docs.
Oh, that's so
Woohoo!
cute. Thank you.
Thank you so much for helping thoughtfully and candidly explore fertility questions. I was hoping you could talk more about how to navigate when procedures meant to help promote fertility encounter plot twists with cascading impacts on fertility, pregnancy, and birth. I had a scheduled uterine polyp removal, and there was a complication when there was a small cervical laceration caused by a single tooth tenaculum. Second
Hmm.
plot twist, it was a fibroid. I recognize there are many more serious complications, but it got me thinking, what sorts of complications should we be mindful of in terms of effects down the road? And do you have suggested follow-up advice in general?
Oh,
That's a
I
really
think
good
she
question.
must be a writer. I think the way she wrote that, the whole plot and the twist in the plot, I think that's very cool the way you wrote the question. And I like the adjectives that you used. So cervical lacerations, I don't like using single tooth tenaculums if I can help it. But sometimes when you grasp the cervix, it just sometimes the cervix is really kind of tears more easily. And sometimes if you don't get a great bite, it can tear. Really, the biggest issue with the cervical laceration is the moment you're there. I mean, the cervix can bleed. And so you just have to be able to get the bleeding under control and get it sewn up. And generally, the nice thing about the cervix, because it does have so much great blood supply, it usually heals up really nicely. So it really doesn't cause a long-term issue at all. And what would you like to say about polyps, Carrie, that turn into fibroids?
So when you're doing the initial testing to determine like a saline ultrasound to see if you've got anything in there, you cannot tell the difference between polyps and fibroids. Sometimes it's clear. Sometimes you can
Yeah.
get a pretty good idea of what you're going in for, but a lot of the times you can. And so you're just dealing with whatever. And to a degree, we're playing the odds that most of the time it's just a polyp. And if it's a fibroid, you can usually see because there's more fibroids or the shape of it. You can kind of get an
Hmm.
idea. But a lot of the times you just don't know. And so um, the plot twists, there's two kinds of plot twists. There's the plot twists that are just kind of vaguely interesting, and there are the plot twists that really change the story. And so it's very interesting when you're talking to patients because most patients treat every plot twist as one that's going to change the story. Most physicians see the majority of those plot twists as something that's
Twist in
mildly
the road,
interesting.
turns in the road.
Yeah, like it'll
Hmm.
get you through that chapter, but it's not going to affect the ultimate outcome.
Yeah,
And
good point.
so both of the plot twists that you have described, not to discount anything that you've been through, because as a patient, it's super scary when the doc says, "Oh yeah, I had to do this and I wasn't planning on doing this." But a cervical lac is not really going to change anything because the majority
Hmm.
of those, if your doc needs to, she'll toss a couple stitches in and you're done for a fibroid, assuming that you've got the capacity in the OR that you're in to take them out, which is not true of every single OR, especially in some of the office ones. You may need to come back and do another procedure, which has financial implications and scheduling implications, but usually that's about it. Maybe some timing implications. It doesn't effectively change what's going to happen in the end. It may take another month or so, which in fertility days feels like for freaking ever. But in the actual context of life is nothing, which is something that a lot of our patients really struggle with because every day, every hour, every second that you're having to wait feels like an eternity. But when you pull out and you think, okay, if this was my mother telling me to wait for an extra week or so, or an extra month even to figure something out, it doesn't really, like, that's not going to change the end of the story. So I love this question because
I
it's
do
a
too. This
very,
is a creative question. I like it.
yeah,
It's
it's
a
it's
good one.
very interesting. It's very different than what we deal with. And there is a distinct difference between how the docs look at it and how the patients look at it. Because most of us are pretty blasé about of,
Yeah.
we see this all the time. This is not a big deal. But patients really get caught up and anxious in it when that's fair because it's their body, but it maybe not be worth all of the effort that they're putting into it because it's not functionally going to change the end of the story.
Yeah, I think
So the story will have a happy ending, we think, right?
right,
Yes.
right.
Yes.
And kind of to carry on with what Carrie said, is that realize that your physician has done a lot of training to see a lot of different scenarios and how different things happen, and probably has been in practice for a reasonable amount of time. And so it's it's unusual for us to have something happen that is that completely catches us by surprise.
Yeah.
Okay, because we're watching for all these things. We know it's like this may happen. If this happens, then we're going to do this, and it's just one of those. um it's hard to understand that there are multiple outcomes, and not all of those outcomes, even though they weren't necessarily the primary outcome, are necessarily bad. So that's part of putting faith in your physician.
And if you have a good physician, your physician should be thinking. I always say, as a physician, we have to think worst case scenario. That rarely happens, but you want your physician to think, okay, what's the worst thing that could happen? What do I need to do to be prepared? So, your physician should be prepared for if this, then that, So
That's what we do.
generally, that's what we do.
And part of that question was what are the really big and important plot twists? For the majority of uterine procedures that we do, the most important plot twist that is actually going to change the outcome is if you have intrauterine scarring. And
Yes.
that is thankfully an extraordinarily rare outcome because we're all looking for it. And if we see something that's going to make us more likely to encounter that, we're going to back off on it. And even when you have people who are not fertility docs specifically doing those procedures, it's still really rare to see that outcome. And so I would say that's one of the biggest one in the type of procedure you're describing that can change the outcome substantially, but it is, knock on wood, so extraordinarily rare that it's not something that we functionally have to worry about. We just do it as a mental exercise of, okay, how do I prevent this? Because I just don't want to go there at all.
Exactly. All right, our next question. My husband and I want to freeze embryos for baby number 2 and then get pregnant naturally for baby number 1. I'm 33. No kids yet, but we want to. Got pregnant in August of 23 without trying and miscarried at 9 weeks. Fetus measured about just shy of 6 weeks in the ER. Saline and HSG normal, day 3 labs, AMH 1.61, FSH 4.9, estradiol 28, prolactin normal. I have hypothyroidism, but taking levothyroxine for 3 years. Thyroid profile normal, no Hashimoto's. Semen analysis showed motility at 36%, everything else normal. Would you support doing IVF to freeze embryos for second baby now and try to get pregnant naturally for baby number 1 right after IVF cycle? I'd like to try to get pregnant naturally with ovulation induction and open to IUI.
Yeah, I mean, I think that'd be a great plan. I think it's a great plan. Yeah, why not? Because your eggs now are much better than your eggs are going to be, or in theory, a 33-year-old, maybe not much better, but the younger you are, as fertility doctors, we always say no time like the present. So if you're willing to do that, that'd be great, because most of the time when somebody freezes embryos like that, down the road, they're like, when they get to be 38, 39, they're like, hey, let's have baby number 3, even with those embryos, because we know that those embryos are genetically normal. So yeah, I think that's a great plan.
Mm-hmm. When you're looking at whether or not you need to do ovulation induction or IUI, something like that for your first baby, I would say give it at least 6 months trying on your own before you do that. When you look at a quick run of the statistics, your chance of getting pregnant each month is somewhere around the 20 to 25% range with where you are right now, meaning you have not tried to get pregnant and have not had to do anything above and beyond that. So in the first 3 months, 50% of couples are going to get pregnant. In the first 6 months, it's 75% of couples. By the time you hit the 1 year mark, it's roughly 85% of people.
But she did already get pregnant in August, and we're
9-week loss.
But I thought she said that she hadn't really tried beyond that.
It wasn't protected. That's trying.
I mean, that's fair. That's fair.
That's
Do we
trying.
tell you about that definition, Carrie? We talk about that a lot.
I
No,
know, and I'm always harping on that.
But
Okay,
yes, you can
that's
try
fair.
on your own for at least 6 months. But if you've tried for 6 months and not successful and you're in your mid-30s, it's reasonable to seek out help.
Yeah, that's legit. Okay, fine. But when you try to conceive right after IVF, oftentimes people have a higher likelihood of succeeding just in those first couple months. We think because of the way that the hormones have been given and they've just kind of kickstarted everything. So I think it's a great plan too.
I had a patient recently who did for 2 IVF, been trying to get pregnant for a long time, did 2 cycles to freeze embryos. The first cycle she had a few, but she's like, I just want more. She did a second cycle. Before we could do her first transfer, she's pregnant on her own.
Love it when that
It
happens.
happens.
All right. So, topic for today is preparing for IVF. And that is a huge, massive topic. And so we're going to narrow it down a little bit and talk about how do you prepare for IVF with respect to medical conditions in particular. And so what things do we look at? What things do we worry about? Medications, all of those things. So for you ladies, when you are taking a history for a patient who's coming in and you know she's destined for some type of fertility treatment, whatever it may be, what are some of the big things that you look for right off the bat?
So one thing that we're going to ask, and oftentimes we don't get a full answer, we're going to ask you what other health conditions you have. And oftentimes I see people leave this blank, and then I go down and look at their surgeries, and they've had some sort of surgery that clues me in that there was something else in that health history. So though it may not sound like it's relevant, we need to know about all your other health issues for you and your partner. And so those things can include things like asthma, diabetes, history of cancer. These are all things I've seen left
really
off.
important. Oh
really
yeah.
important things. It's like, oh, port placement. I'm like, why exactly did you have a port? Oh, I had a terrible infection in my abdomen and I had to have IV antibiotics for a month,
Yeah.
different
Or you
things like
or
this.
you notice they're chronically on Lovenox, and you're like, well, why are you? Oh, well, I had this clot in my lung, this pulmonary embolus, and you're like, that's kind of important to know about.
So
So,
even though you may not think it's related to your fertility specifically, we still need to know the full picture of you because your safety and well-being is our number one priority.
And anything, and the way to think about that too is anything that can negatively impact your body that you take medication for could negatively affect your baby. We've got to really just make sure that that's been looked at and evaluated by somebody that is qualified to evaluate that, and make sure that it's safe for you to be pregnant at that point.
so when you ask about medications that someone is on, what all is included? When you say what are you taking? Patients sometimes think of that a little differently than doctors think about it. So, how do you guys think about it? When you ask somebody, what are you taking? What medications are you on? What does that include in your mind?
Anything that you put in your mouth is a medication for me. Anything.
Or inject
So,
Yes.
yourself with.
or inject yourself with. And that, I think people forget that a lot. Like, and I know we may mention this in a minute, but some of the weight loss drugs, people don't think about that because they only do an injection once a week and they don't really think about that as being a medicine. But that's a big deal, as we all know.
So I usually say medications, vitamins, and supplements. All of those things. If you are not consuming something because it's relatively food or liquid, we need to know about it.
Yeah.
So, but vitamins and supplements are not prescribed. So, why does that matter?
Because some vitamins and supplements can actually be harmful if you're taking too high dosages of them.
Mm-hmm.
The one I always think about is vitamin A. I have
A,
a lot of
yeah.
patients who are on like these superfood things that have lots of A, D, and K and things like
Mm-hmm.
this. And so we really want you taking that vitamin D. Vitamin A at high levels can actually be harmful for a developing pregnancy. So, realize that just because it's a vitamin or supplement doesn't mean it's safe. Okay. And we also know that sometimes those things can negatively impact pregnancy chances or baby well being.
And sometimes two people will double dip and not realize they're doing that. Like they'll take a prenatal vitamin or a regular multivitamin, and then they'll take some other supplement pack that they get from, some sort of supplement place, and it'll have a bunch of other like mega doses of A and D and all these ones that are stored in the fat cells. And so the ones that you excrete in your urine are not as problematic, things like folic acid. But like Susan said, ones like vitamin A and that sort of thing, ones that are stored in fat cells can be problematic. And so even if they're vitamins are good, but just like everything else, you've got to take them in the correct dosage.
And how do we know what the correct dosage for any given person is and that they're getting that correct dosage?
Well, that's kind of a little bit controversial, as we learned from one of the people that we talked to. The recommended dietary allowances apparently were developed back in World War II for men, not for women. And so, but
And
that's
they were
really about
minimum
the
requirements, not actually like
exactly,
fully
yeah.
nutrition
Like
requirements. It was
optimal
what
requirements.
do, what do we need to do to keep you alive, not to make you the best you can be.
Yeah, and I think that's really controversial in the prenatal vitamin world too. There's certain prenatal vitamins that are really lean and mean. They don't have a lot of things in them. They assume that patients are eating a healthy diet and don't want patients to get too much of certain things. I personally think some of those are a little too lean. I think most of us don't eat a great diet, even though we maybe think we do. We're probably missing some supplements that we need. I mean, generally, over-the-counter prenatal vitamins generally have about what you need, but again, some people could argue that things like choline and calcium and vitamin D are left off, and those are also really important for pregnant women too.
Mhm. So, once you go through somebody's medical history and you ask about every single medical condition they have, every single surgery they've had, everything they're putting in their mouth, and all of their allergies, all of which are relevant. And so, one final plug for even if it's not related to your reproductive system, we still want to know because there's impacts. What are some of the most common things that we hear about in patients,
High
medical
blood
condition wise?
high blood pressure is probably one of the more common ones. And I think young, healthy women sometimes live in a little bit of denial as they feel like they're young and healthy, and they are. But you can't outlast your genetics. And so if both of your parents had diabetes, you you're probably destined to get it at some point. And sometimes we'll see patients that are preparing for IVF, and they'll come in and we'll check the blood pressure, and it'll be like 140 over 100, and they'll be like, well, I was just kind of stressed. And then we'll recheck it again, and it might be 150 over 100. I'm like, no, that's a little bit more than normal stress. And so sometimes patients will really have some pushback on us, because they don't want to go get checked out for high blood pressure. And I get it. You don't want to be labeled with a condition, but the point is, if you have the condition, we want to treat it so that your baby can get really good blood flow during pregnancy. Because when you have high blood pressure, it like squeezes the blood vessels and decreases the blood flow to the baby. And for obvious reasons, that can lead to some complications. The other reason we want to manage it ahead of time, it's better to get you under good control and get you on the correct medication before you ever get pregnant. We don't want to be playing catch up after you get pregnant. We want to correct all these things on the front end so that we don't have to do that at the end.
I think one of the things I see often is a history of asthma. Asthma is very, very common in the population. And some people just have asthma in childhood. And there's other people who have exercise-induced asthma. And there's other people who have like serious, big, bad, could threaten their life asthma. And so, especially going into IVF, because you're going to undergo anesthesia for your egg retrieval, and we need to make sure you're oxygenating well and not having any reactive airway disease at that point. A lot of people as adults, they're like, oh, I just use my inhaler here and there. Well, the reality is, if you're using your rescue inhaler more than twice a week, and you're having to do that because you're having asthma symptoms, you probably need to be on something else in addition to help maintain your breathing. Obviously, having good oxygenation and having a baby go hand in hand.
That's a good thing.
It's a good thing. And it's one of those things, especially, if you're having seasonal issues that people are like, oh, it's not a big deal. But if you're using your rescue inhaler more than twice a week, or you're somebody that has actually been hospitalized, especially as an adult, for your asthma, touching base with your pulmonologist, your lung doctor, is a very good thing to do.
Well, the obvious thing with asthma too, if you think about it, you've got a baby growing in your stomach, and your baby's growing up, but it's also growing out, and it just compresses your lungs. So your ability to take big, deep breaths are more and more difficult, just because simply it's impaired because of the baby. So, it makes sense that if you have asthma, that, it could get worse. And I think I remember about a third get better, a third get worse, and a third stay the same. So it's important to get checked out about that ahead of time before you get pregnant.
So one nuance of questions that we ask and what we are looking for versus what patients hear. So we often ask, what medications are you taking? And what that means to us is, what medications are you taking right now? What medications should you be taking that you're not taking? What medications have you taken in the last, usually at least year or so, that even if you didn't take them right now, like a rescue inhaler, we still got to know about it. Oftentimes what patients hear is, what did you take today?
Yeah.
And those are two very different questions. And so, probably the better way to phrase that is, tell me what medications you're taking or should be taking or have recently taken.
Mm-hmm.
So we want to know about all of
it. I think we see that a lot also with people who have kind of borderline thyroid disorders, that, maybe they were on thyroid medication during a prior pregnancy, or have had a period in their life that they've previously been on thyroid medication, or just kind of was taking it for a while and then just happened to stop it because they really didn't know if it actually made a big difference. And, thyroid function is very important going into pregnancy. It's your major metabolism gland. It's very important for healthy baby brain development. And so that's also an important one for us to make sure you have your I's dotted and T's crossed. And often your reproductive endocrinologist will kind of take over your thyroid care while we're helping you achieve pregnancy and during early pregnancy, and then transition that off to either your OB-GYN or your general endocrinologist.
And just know the bar is different for you when you're pregnant. I always say, if I have two partners, a male and female partner sitting in front of me, I say, or two females for that matter, if you're the one that's trying to get pregnant, we want your number to be, less than 2.5 for your TSH, your thyroid stimulating hormone. Your partner not trying to get pregnant, their number can be up to like 4 or 5, depending on the lab. And so there's a different number for you if you're either pregnant or trying to get pregnant. And so to what Susan was saying, every time we check a thyroid and it comes back abnormal, I always have my nurse ask, have you been on thyroid medicine? Are you supposed to be taking thyroid medicine? If you are, what dose are you on and what have you been taking routinely? Because all of those will change what I give them. And, if they supposed to be taking 25, but they didn't take it, then, take it for 6 weeks, 8 weeks, we'll recheck you again. It really changes the dose depending on, if you've been on it before or not. And sometimes people will have endocrinologists who will be controlling them. And generally in that situation, I usually defer to their endocrinologist and just say, let your endocrinologist know, this is the number that we got. They may or may not want to adjust it, because sometimes for some patients that are on really, really high doses of thyroid medicines, it's really hard to finally adjust them. So we might live with a little bit higher number, but generally we want it less than 2.5.
So, Susan, you mentioned that sometimes we'll take over and manage the thyroid. Are we going to do that with blood pressure, diabetes, asthma, everything?
No.
No.
Because remember, we're reproductive endocrinology and infertility physicians. So endocrinology includes the thyroid gland. So that is something that we're trained to do and to deal with on a regular basis. So some of these other things we've had some training in. Most of the time, those are things that we do defer your primary care doctor or your cardiologist or your pulmonologist, whoever is handling those things. We will work with them. You hear the phrase, it takes a village to raise a child. Well, it also takes to make a child sometimes, and that's okay.
Yeah.
And we invite these people to come into our village because they're really good at what they do. I know I'm always happy. Sometimes some of those other doctors are like, "Oh no, you're trying to get pregnant. We don't know which medicine to prescribe you." And I'm the type of person who I'm like, you tell me what you want them to take, and I will let you know if that's a good idea. Because I don't know all of the medications, but I can research the medication and make sure it is something consistent with good, safe, healthy pregnancy, and say, yes, we're on a good plan, or that's not necessarily the best one I'd like. I might be able to give some options, or say, why don't you give me another option of something else we might be able to try that might give us as good a results.
I will say, for any condition, what your reproductive endocrinologist would love when you come in to see them and you're ready to get pregnant, if you go, okay, I have high blood pressure. Here's a letter of clearance from my primary care doctor. Oh, I also have this cardiology issue. Here's a letter of clearance from my cardiologist. He's worked this all up. He thinks it's going to be fine for me to get pregnant. We would love that, because usually it's the other way around. Usually it's like, oh, sorry, I really need to get a clearance from this person. Make sure you're healthy enough to get pregnant. And like Susan said, we know enough about the condition to know how it can impact pregnancy, but we don't know enough about the condition to be able to treat it. That's where your cardiologist or your nephrologist or your endocrinologist, if they're managing diabetes, come into play and kind of help us determine what we need to treat you with to make sure you're healthy enough to be pregnant.
And most other docs won't necessarily give you a clearance to get pregnant. They'll think of it more as an optimization.
Yeah.
You are as optimized as you can be to get pregnant, because even when you've got someone who is healthy with absolutely no medical issues, pregnancy still has risks. And that's true of pretty much everything. And so they're not thinking of, yes,
probably one of the most dangerous things any woman in the Western world does in their life.
Pregnant.
So, I mean, it really is. So that's why Carrie's saying that even under the best of circumstances, that doesn't mean everything's in the clear, but it is a risky thing. Most people end up being completely fine, but we want to make sure everything's as good as we can make it.
Well, and a great example of that is epilepsy. For many years, we've known a lot of drugs that people need to treat their epilepsy can be harmful to a baby, although it's gotten better now. We know monotherapy with just one drug is better than being on several different ones. And there's certain drugs that tend to be a lot better, but there's still some risk that the neural tube, the baby's backbone, won't form correctly. And, it's kind of one of those things where you have to look in the risk and benefits when it comes to that medication, because, if you have really bad epilepsy and you're driving your car and you have, if you have a seizure and you crash your car, that could kill you, So we would rather you run a low risk of maybe having some issue with your child, as opposed to you driving your car and having a wreck and killing yourself. And so it's just, you always have to look at the risk and the benefits with every medication that you use. There's a lot of medicines are not 100% proven that they're healthy in pregnancy or do fine in pregnancy. But a lot of times we have observational data from people that have had to take them for many, many years that will demonstrate that, yeah, probably this is a drug that's pretty safe in pregnancy.
And kind of along that, people will come in and be like, I'm taking blank medicine. And medicines are easier than when you're talking about supplements. But the way medicines have now been categorized, used to they were categorized on safety based on an alphabetical thing. It
A
was
weird,
like
weird alphabetical thing, A, B, C, D, X.
right. But that has gone away, and really a lot of it comes to risk versus benefit, because for you, particularly in your circumstance, maybe you've tried all these other medications and you've been allergic to them or had bad side effects or they didn't work for you, and this one medication is the only thing that will help you. We understand that that may have a risk to baby, but in your specific circumstance, it comes down to risk versus benefit. And so that's what kind of pulls your doctors in different directions, and why maybe your doctor said that this is the best thing for you to be on, but your sister may be on something else.
Yeah, and one other thing to think about with drugs, and this is very applicable a lot in the world of depression. If you have severe depression, that can kill you too. So there's certain drugs that have been around for a long, long time that we think are probably okay and probably safe in pregnancy. But if you try that drug and you still have severe depression and that doesn't control you, then you may have to use a newer drug. And we would prefer, if it's a debate between a newer and an older drug, we like older drugs because they've been around longer. We've been able to kind of see what happens when people take them, even if it's not randomized prospective data. We have observational data. So for a drug like Prozac, it's been around for probably close to 25 years. And, we kind of know it's probably safe for people that have depression. But if that doesn't manage your depression, then that's not helpful for you. You may have to use a newer drug. But if it's a debate between the two, we prefer to prescribe older drugs rather than newer drugs.
And to piggyback on that, sometimes people are like, oh, I just want to be off all medicines because I
Yeah.
think that's the best thing for me. And that is actually not true. It
Not
is
the best thing.
better to be on medicines, have these things controlled, even things like depression, mental illness, because you're like, how my brain and my depression or anxiety affecting my baby in pregnancy? And there are actually very good studies looking at people who have uncontrolled mental illness issues such as depression and anxiety, and those who are treated with medications have better outcomes for pregnancy and their long-term children if things are well controlled. So no medicine is not always the best medicine.
Well, you just don't want to stop a medicine abruptly, too. Things like Prozac and those types of medicines, if you stop them quickly, serotonin reuptake inhibitors can cause some side effects, too. So you really want to make sure whatever medicines you're on, you do it in conjunction with the prescribing doctor, and just let them know that you want to be pregnant. And, generally we think that most of the time when it's a young, healthy woman, reproductive age, a lot of times the doctors will take that into consideration, but just be really clear with the doctor and say, hey, I really want to be pregnant. Is this safe in pregnancy? And that way they'll be thinking more in terms of that as opposed to in terms of other things that they may consider when they're trying to put you on medicines.
I have a question for you guys. I generally, once in a while, we'll have somebody in and I'm like, oh, we want to get that changed because we're actively pursuing pregnancy. We're going to be doing these things. And sometimes I get the response, oh, my doctor said just contact them after I'm pregnant and we'll change it then. I disagree with that philosophy. I'm like, if you're going to be on something different during pregnancy, let's do it, because we are putting like our best foot forward to help you get pregnant. Do y'all kind of follow the same thought process?
Oh yeah, because you guys know lisinopril. Some of those types of drugs can affect the formation of kidneys. You don't want to find out about that at 13 or 14 weeks or change it. I mean, that's all happening right after you get pregnant. So you want to make sure that you're on the right medication before you ever have the first positive pregnancy test.
Because when you look at the potential outcomes for that, one is that you don't know that you're pregnant right away, meaning you've been on the offending medication for several weeks into pregnancy, and most of the organogenesis where organs are being formed, that happens right up front. And
Real
so
early.
a lot of that may have happened by the time you're able to switch over the medication. So that's one potential option. Another potential option is, let's say the second you get pregnant, you are still a minimum of 2 weeks into formation of that baby at that point. And when you're coming off of something, oftentimes you cannot just cold turkey stop and go straight onto something else,
Yeah.
which means you have a period of time of unmanaged disease at that very early critical point. Or you can change it before you ever get to that point where okay, if this doesn't work, then we're going to switch things up and get it so that it does work. And so you are optimized going into pregnancy. So that's part of the reason why we really prefer getting everything dealt with before you hit the point of positive pregnancy test.
So diabetes is a big one we haven't talked about, and that's one we see fairly commonly.
But we did talk about it in episode 205. So if you want all the information on that, then
thank you, Carrie.
An entire episode dedicated to it relatively recently.
So one of the things, oh, go ahead. Sorry.
I was going to say, let's talk about all of the autoimmune, just a quick.
Let me say one thing about diabetes, and we won't dwell on it since we dwelled on it. But hemoglobin A1C, if your doctor's not looked at that, particularly if you're on the heavy side of things, it might be a good idea, because if you come to see us and you're ready to get going, and this happens a lot, particularly in patients that are heavier, we go, well, okay, but we just need to check your hemoglobin A1C, and it needs to be below a certain number. And nobody's 100% on the page of it exactly has to be this, but generally under 6 would be great. Some people would say under 7, but hemoglobin A1C needs to be in a good range. And until it gets in a good range, we can't do anything to get you pregnant. So if you're listening to this and you think you have diabetes or you have a family history, it'd be a great idea for somebody to just check that before you ever see the reproductive endocrinologist. Try and get that under good control.
Mm-hmm. So let's do real quick 1 or 2 other big classifications of disease. Let's start with GI disease. So gastrointestinal, things like IBS to Crohn's to ulcerative colitis to ulcers. How do you guys approach those in general?
Don't forget celiac.
And
yeah, I was going to say,
yeah.
I'm just holding weight. I know this is Susan's topic, so I'm just sitting here.
So to be fair, my next one was going to be autoimmune, which I figured is totally Susan's topic. So
for your gastrointestinal disorders, they need to be under good control. And there's a lot of people who have a lot of the things that Carrie just talked about that may have seen a gastroenterologist 3, 4, 5, 10 years ago. Like, we see this very commonly. And it's like, oh, well, I'm fine. I haven't had to go to the doctor. And going to the doctor does not necessarily mean fine or not fine in our world. And so if you have a history of a major GI disorder, go see your local gastroenterologist. Just get, if there's chemistries that need to be checked, or you need to have your colonoscopy or your EGD where they look inside your upper intestine, like, get those things taken care of beforehand, because we're going to ask you to go get them taken care of. So just take the best foot forward for those.
Absolutely. How about some of the autoimmune diseases? So there's some overlap, GI and autoimmune, when you're talking about celiac and Crohn's and ulcerative colitis. And then you've got your separate, more connective tissue disorders, things like rheumatoid arthritis and lupus and that family of conditions. How do we want to approach those?
I mean, we just got to make sure that you're in the best position you can be, i.e., we don't want you to be in the middle of a flare, because basically your body is under siege or feels like it's under siege if you have a flare of rheumatoid arthritis or some other autoimmune condition. Doesn't matter if it's in your joints or in your GI tract or wherever. And so this can be really frustrating, because I think, at least in the rheumatoid arthritis world, it may be looked at a little bit differently, but there's certain markers that your doctor will look at to say, yes, this person is stable or this person's in a flare. And then the second part of that is we need to figure out that the medicines that you're on are ones that we think are relatively safe to take. And usually, there's a rare, I can't think of a situation, maybe you guys can, but most of the time, GI doctors are in tune with this. Rheumatologists are in tune with this. Most bioidentical drugs, or not bioidentical, what's the word I'm looking for? Biologics. Most biologics are safe in pregnancy, and as long as you're stable. But the key is you can't be in the middle of a flare, because if your immune system's attacking your body, we don't know how it's going to impact your fetus, and probably it's not good, probably not in a good way.
One thing I would encourage you, though, is if you're struggling with fertility challenges and you haven't been to see a reproductive endocrinologist, this is one of those times that I'm definitely like, go see both of them at the same time.
Yeah.
Because if you have an autoimmune disease, unfortunately, autoimmune disease can sometimes attack your ovaries. So people who have autoimmune diseases are at risk of having multiple autoimmune diseases. And we often see people like this come in and it's like, oh, we've just been having trouble getting pregnant. I have this long history of ulcerative colitis or, rheumatoid arthritis. I'm doing my tongue tied this morning. And that shouldn't have any bearing. And we go and we do your ovarian reserve testing and we're like, oh crap, we need to get moving on this. We need to your point. Rheumatologic stuff is in order, but time is also ticking. So, if you're 32 and your time's ticking, that's one thing. If you come in and you're 40 and you've got something going on and, all of these things kind of flow in together. So we have to balance what we're looking at. But coming and seeing somebody like us sooner than later is probably a good idea.
Yeah, and the one other thing I would throw in, this is not the same topic, but on a different topic, I was just thinking about things that I've seen recently. I've had a run of a couple of people lately who have been 39, 40, and generally the recommendation is to get a mammogram at age 40. And sometimes if patients are at 39, kind of close, I'm like, once you get pregnant, if you breastfeed for a year, maybe even up to 2 years from now before you're actually going to have a baseline mammogram. So I really encourage even 39-year-olds to go and get mammograms. And over the years, in fact, last year, about a year and a half ago, I sent a patient for a mammogram and she had breast cancer. And so that's the kind of thing you don't want to find that out after you're pregnant. And go ahead, Susan.
Oh, I was just wanting to go off of that kind of the routine things we need to take a look at. In addition to things like getting your mammogram, if you're planning on trying to conceive and carry a pregnancy beyond the age of 45, a lot of the people who come to see us don't know that you are going to need to get a cardiac evaluation. We know that women who carry pregnancies over 45, a lot of them do great, but pregnancy and delivery is, again, one of the hardest things you're going to need to put your heart under. And we know that women over the age of 45 have an increased risk of cardiac events. So we'll want to get that checked out. So don't be surprised if we say, hey, you need to go see a cardiologist. And you're like, but I'm fine. We want to make sure you truly are fine, because as much as we want that baby, we want you more.
And about 40% of your blood flow is increased, or blood volume is increased by about 40% when you're pregnant. So your heart, is the mechanical pump that gets all that blood through your system and through the placental bed as well. So your heart's working so much harder when you're pregnant than it is when you're non-pregnant. And if you add, age factor onto that, we just want to make sure that you're not in early cardiac failure and you don't know about it, or that you will be in cardiac failure if you're trying to pump that amount of blood.
All right. So that is covering a huge amount of ground very quickly.
Quick and dirty.
When I think about it, I'm like, oh God, I've got a huge list still to go of things to talk about, but we'll pause right there. And to our audience, thank you so much for listening. Be sure to tune in next week for more. Be sure to subscribe, please. Leave us a review, please. We love to hear from you. We're on Instagram, Facebook, YouTube. Stop on by, leave us a like, a hello, a comment, and we want to hear from you.
You can also visit us on fertilitydocsuncensored.com to submit specific questions. All questions will be answered just like today for the Ask the Doc segment. Leave us episode ideas, and remember, we're doing an IVF book. So if you have any tips you want us to put in that IVF book, you let us know, because we're writing it as we speak.
Also, Apple has recently changed their algorithm, and if you have subscribed to us in the past, you may not still have your subscription. So go back and resubscribe to us, because we don't want you to miss out on anything. And as always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
Bye, everybody.
Bye.